Tuesday before Thanksgiving after a long grueling semester. But I thought maybe we could show a funny clip to kind of wake us up this morning before we kick off our block 4, our last block. Hopefully I woke you up, but there is a point to this. This block, we're going to be learning about arrhythmias and then how to manage them, which involves being involved in a code response. And hopefully your first code response will not be as chaotic as that. Hopefully you'll feel a little more confident after this block of lectures to be able to respond in the event of an emergency and in a code like that. So today we're going to do a review on EKG. If you look back at where we have been, you can see we've come a long way in the 3 blocks that we've completed so far. You guys did very well on the test yesterday. Definitely a difficult block conceptually to understand the pathophys of what's going on in the different types of pathologies. You guys did very well in that endeavor, but you also saw a lot more information is necessary to like the question stems to be able to guide you to the correct answer, right? A lot of folks were running up against that 75-minute mark and had the test auto-submitted. So just being careful as you go forward, learning how to pick out the details that you need in that clinical vignette quickly to come up with the correct answer, because you only get a minute per question on the PANTS and on like the PAC-RAT and all the other standardized tests you're going to be taking during phase 2. So working on reading through, picking out the data that you need quickly to come up to the correct answer. But yesterday was a very good day. So we start off this lecture series with a review of EKG. I know you did a full class on EKG, but that was at the beginning of the semester. That's been a long time. And EKG is one of those things that if you're not actively practicing using it, you lose the skill, right? What do all those little squiggles on that piece of paper mean? And how do I recognize that something is wrong? So we're going to take today's lecture just to kind of review, because it's important that we do this block now, because now you have the understanding of the different pathologies of the heart and why the different arrhythmias develop. If we did this class immediately after EKG, you don't have that concept of understanding of why the different pathologies might cause the arrhythmias that we're going to see and we're going to learn how to treat. So, but I wanted to start today's lecture off with a case when I was a resident. I was the night admitting resident for the Fort Belvoir Hospital. And I got a call from an outside facility from an ER physician that said, I have a 55-year-old male who's coming in with chest pain, and when I did his EKG, it looked really weird. There's lots of weird things on it. I'm not sure what's going on. It's not as STEMI, but it just looks very weird. I'd like to transfer him to you all so you can do a cardiac workup on him and make sure that he's okay. So he arrived, this was about 11 o'clock at night, 12 o'clock at night. He arrived at Fort Belvoir at 3 in the morning. And I'm looking through the paper records, and I pull up his EKG, and his EKG says, consider limb lead reversal. Now, granted, I know we're not supposed to look at the computer reading, right? You're supposed to be able to determine that on yourself. But the computer read is probably 90%, 95% accurate most of the time, right? So I look up, well, what's the criteria of limb lead reversal? And sure enough, he met every criteria for limb lead reversal. So at 3:30 in the morning, I call up to the nursing station and say, can you repeat his EKG? And lo and behold, EKG, stone cold normal. We admitted him to get a cardiac rule out. He was being seen for chest pain. He's a 55-year-old male. So we did the cardiac workup to include the myocardial perfusion scan, which showed no deficits, completely normal. He was discharged at noon the next day. All because they switched the left and the right arm lead. So we did a $10,000 workup, coordinated a transfer from an outside facility via ambulance for a limb lead reversal. So techniques matter. It can save money. It can also save morbidity for your patients as well. Because what happens if we were doing an aggressive approach and we did cardiac catheterization on them? Or what happens if you had a reaction to the radionucleotide that we had to give him in order to do that myocardial perfusion scheme? So there's risks for our testing. There's got to be a good indication. And a mistake on our part could lead to morbidity for the patient itself. Now remember, when we talk about EKG, what we're looking at is we're looking at the conduction of an action potential through the heart. And there should be a normal process in this, right? It should be that that action potential is generating in the SA node, right up here in the right atria, which corresponds, of course, to the P wave, right? And that action potential generation is going to go from point A to point B, which point B is going to be your AV node. And it's going to get that way by going through the internodal pathways, which there's 3 to get down to the AV node. But we also have to get that signal over to the left side to trigger that and coordinate that contraction. And that's where Bachman's bundle comes in, where it carries that action potential from the SA node over to the left atria to trigger that left atrial kick. Once that action potential gets to the AV node, it's going to pause for a brief period of time before it then sends it down, the action potential down through the His, and then through the bundles and Purkinje system, and then of course the fascicles to coordinate that normal squeeze of bottom up, right? It's like a toothpaste. We want the bottom to squeeze first, so we have that one directional flow of blood up and out of the heart, instead of some of that effort being wasted squeezing it down to the apex of the heart, right? You learned in radiology, one view is no view, right? Same goes with EKG. One view is no view. So in your standard 12-lead EKG, you actually get 2 views to kind of get a 3-dimensional understanding of what is going on in the heart. And we divide these 2 views in the frontal plane, or the limb leads, and then the horizontal plane, or the chest leads. And there's a difference when we look at the leads in the view as far as what information we are seeing and having to interpret, okay? In the limb leads, or the frontal view, so kind of north to south look, you have bipolar leads, which the computer does this, where it's going to make one lead, one specified lead, the negative lead, and one lead, the positive lead. And that deflection, or that waveform that you see in that lead, is based on what is the action potential flow towards that positive lead. If it's going towards it, it's going to deflect positively. If it's going away from it, kind of towards the negative lead, it's going to be a negative deflection on your EKG. Whereas when you look at unipolar limb leads, all we care about is the direction towards that lead, which is the positive lead. It doesn't matter where that negative lead is, it's just what is the direction going towards that positive lead. And you can kind of understand when we look at this, why this is important and why it's important to understand which view we actually are looking at, so we can kind of get an idea of what exactly is going on in the action potential, especially when we talk about different pathologies. It helps us understand what's going on. To kind of help you learn which leads are involved in, like, the bipolar leads, look at what the lead number is, and that will tell you how many L's are in the leads, okay? So lead 1 is your right arm to your left arm, so 1 L. Lead 2 is your right arm to your left leg, 2 L's. And then lead 3 is your left arm, 1 L, to your left leg, 2 more L's, so 3 L's total. So that gives you an idea of which direction that flow of electrons or that flow of that action potential is going in that lead. And it also may start to kind of make sense why we say leads 2, 3, and AVF are our inferior leads, right? Because what are we looking at with limb 2? We're looking at going towards the left leg. In limb 3, we're looking at going to the left leg. When we look at AVF, we're looking at the left leg, left foot, right? So we're seeing, in total with those 3 leads, we're seeing that inferior surface of the heart. Okay. Now, looking at the chest leads to kind of help us give that 3D view, now we're looking at a horizontal plane going like right to left, and you can see the leads and how they're arranged are going to give you that idea of what's going on in that in the myocardial wall in that horizontal plane. And this is ultimately what we get when we place our leads in this fashion. So you can see that 2, 3 AVF, or we said, are our inferior leads because we're looking at the left foot, basically, right? Lead 1, we said, was going to the left arm, so that's a lateral. AVL is also lateral because when we look at left AVL, we're looking at the left arm as well. That's our unipolar positive lead. When we look at V1, V2, look at where V1, V2 are. It's right over kind of the septal area, right? And then V3, V4 is our anterior, because remember how the heart's kind of twisted and tilted back. That gives you that anterior view. And then V5, V6 are lateral leads because we're looking at the left lateral portion of the heart. So that's why our 12 lead is arranged this way, and that's why when we see an abnormality on our EKGs, particularly like ST elevations, we can kind of get an idea of what's going on in the myocardium of that heart and how that is impacting the conduction through that area. Now, when we look at the EKG of all the squiggles and the peaks and troughs and all this other stuff, there's a point to it, right? There's something that we're trying to convey with each of those squiggles. And this is where the challenge is, because all of those squiggles can have different criteria and all this other stuff, and that makes this difficult to read. You can see the squiggle, it's just interpreting it, right? So what are we looking at when we see all these squiggles? So the P wave, of course, this is your atrial kick. So this is the contraction of the atria, which is triggered by the SA node. And then it travels down towards the AV node. And that traveling down is what gives you that hill appearance to the P wave. And we'll talk about, when we look at the P wave specifically in a couple of slides, why we get this mound kind of appearance to the P wave. When that action potential gets to the AV node, you're going to have a pause, and this is your PR segment. And that pause is based on allowing all of the atria to contract, give time for that blood to actively flow from the atria into the ventricle before that QRS starts, and now you get the contraction and the depolarization of the ventricle itself just actually cause the squeeze of the heart. And you can see as it's coming down, that's your QRS wave. And then there's other segments, other points that are relevant, but then ultimately you get your T wave, which then is your repolarization of your ventricle, so that the whole system can then reset for that next action potential generation and propagation to trigger another cardiac cycle. But when we start to read the EKG, we also have to understand that there is a specific calibration to the EKG to kind of help us understand, especially when something starts to look weird. Looking at your standard calibrations is important because maybe somebody came in and changed the settings on you so that now things are going to be distorted, right? So like the example of that clinical case, getting that weird finding on your EKG, what should have happened is a nurse or a provider should have gone in and checked the EKG themselves. Let's check that calibration. Let's check the equipment. Let's check to make sure our processes are correct before we diagnose this person with atypical chest pain requiring a $10,000 cardiac workup. And one of the simple things as far as the standard setting is how fast the EKG is writing. You can manipulate this on your EKG machine. You can manipulate this so if it's like going too fast and you want to slow it down so you can kind of get some of those waveforms from blending in with each other, you can manipulate this writing speed to help you with that diagnosis. But standard EKG is going to write at 25 millimeters per second. And by having this writing speed, what that means is, as far as the width goes, one small box will equal 1 millimeter, which equals 0.04 seconds. Okay? If you have one large box, that equals 5 millimeters, which equals 0.2 seconds. Which, okay, 25 divided by 5 is 5, right? 5 times 0.2 equals 1, right? So that's kind of how you can do the math to see what that writing speed is. It also will say it on the EKG itself. When we look, though, at the height, this is important, and we're going to talk about this in 2 slides from now. But you got to check the calibration also for that, because the amplitude can change, which then also can change what you are seeing and what your criteria are for what makes an ST elevation and such. So typically, in a normal EKG, one small box is going to be 1 millimeter or 0.1 millivolts. One large box is 5 millimeters or 0.5 millivolts. Okay, that's a standard and a normal EKG calibration. Now, Dubin's taught you differently. This is how our textbook, Lilly, kind of taught the EKG section, which there's a lot of similarities to it, so don't think that you have to learn my way or the book's way in order to pass this test. Really, it just kind of comes down to just read the EKG and you're going to be fine, right? Whether it be the Dubin approach or the Lilly approach, it's fine. But one of the things that I liked about how our textbook wanted you to read the EKG is the first step is actually to check your calibration. This was something I never learned about looking at when I was learning EKGs using the Dubin approach. So checking your voltage, what does that mean? So on your EKG, you're going to see these little boxes. And what these boxes are indicating is what 10 millimeters, or sorry, what 1 millivolt is, okay? So what is 1 millivolt? It should be, on a normal EKG, 10 millimeters, which we said 10 millimeters is 2 large boxes, and you can see, okay, 2 large boxes. Okay, this is a standard calibrated EKG. But the machine, particularly like in settings of hypertrophy, left ventricular hypertrophy, right ventricular hypertrophy, if that deflection of the QRS is so drastic and kind of starts going off the paper, the machine can auto-calibrate to decrease that setting to the point where now what is 1 millimeter is actually now 0.2 millivolts. So it's doubled, right? And now 5 millimeters is now 1 millivolt. Imagine what that's going to do to the criteria for an ST elevation. So instead of it now being one box, 1 millimeter, upward is now an ST elevation, and now is half a box, half a small box. And looking at like half a millimeter is quite hard on the EKG, right? So you could easily miss an ST elevation if this calibration is done differently from what you normally see. So, so that's why I think checking the calibration and make sure that this is a standard EKG is important, because it could alter how you read the rest of the EKG. So next, okay, rhythm. And what we're looking at is, are we in a sinus rhythm, or do we have an arrhythmia present there? And to be able to say that something is sinus, it requires 3 criteria to be met. You have to have a P wave followed by QRS, and vice versa. So you have to have 1 P for every QRS. You have to have P waves that are upright in 1, 2, and 3. So upright, upright, upright. And the PR interval is 0.12 seconds or greater. So it has to be at least 3 small boxes. So here's start of our P wave. Here's 1 small box, another small box, another small box, another small box. So it's 1, 2, 3, 4 millimeters in length. So we're greater than that 3 small boxes. So that PR interval is good. So this would be a sinus EKG. But look up here. Here's a P wave after the QRS. Here's a P wave with no QRS. Here's a P wave followed by a QRS. Here's a P wave without a QRS, P wave. But now that PR interval is prolonged. We'll talk about what prolonged is in a few slides. But you can see that is doesn't meet those 3 criteria. So this is not a sinus rhythm. Next, let's look at our heart rate. So our heart rate comes from the inherent pacemaking of our pacemaker cells, of our conduction system. And each component of our conduction system has its own ability to generate an action potential, but without any other stimuli, there's a preset on how frequent that action potential will be generated. So we say the SA node is typically our pacing cell for the normal heart, and that's because that inherent pacing is set the highest, to have the highest heart rate. So 60 to 100 beats per minute is what it is normally set if you don't have parasympathetic nervous system stimulating it to slow it down, or the sympathetic nervous system stimulating it to speed it up. Okay, so just in a neutral, no external stimuli, the pacing rate of the SA node is 60 to 100. But then when we go down, you can see now the junctional area is set for 40 to 60 beats per minute. So that should generate an action potential if it doesn't receive a stimuli at that rate. And this is good because we have a redundancy in our system. So let's say we knock out our SA node for some reason. You're still going to have action potentials generated. Maybe not at a rate that meets our physiologic exertional demands, but at least the heart is still going to beat and still going to circulate blood to maybe meet the bare minimum so we're not in cardiac arrest and dead, right? So it's nice to have this redundancy built in to our system. There's 3 ways to count our rate. So you've heard, of course, about the counting method where you're looking at the R to R interval, and you're checking, okay, if you have one large box, it's 300, then 150, 100, 75, 60, 50. This works great in a regular rhythm. You cannot use this method to determine the rate if you have an irregular rhythm, because that R to R for this time may be 300. But then the next one may only be 60. And then the next one may be 75. And the next one may be 150. So it's going to be kind of all over the place. So you can't say my rate is 300 when you only really have 3 beats in the whole 10-second period of time, right? So, so the R to R method, it works great in a regular rhythm, cannot work in an irregular rhythm. So what can we use in that irregular rhythm to count our rate? So you can do either one of the next 2 ways, which is you do a 6-second method where you have these little hash marks. So this represents 3 seconds. So count basically the total number of QRSs in that 6-second period. So this is 1, 2, 3, 4, 5, 6, 7, and then you're going to multiply by 10. Because you have 6 seconds, multiply 10 gives you 60 seconds. So in a 60-second time frame, you now have 70 beats per minute. The other approach is a standard EKG is 10 seconds of time, so you can just count on the rhythm strip from the bottom just how many QRSs you see in that 10 seconds, and then multiply that number by 6 to get you to how many you get per 60 seconds. Okay. So both method 2 and method 3 can be used in that irregular rhythm. They can also be used in regular rhythms too, so don't think that you can't use those, and you're only allowed to use the R counting interval if it is regular. You can use any one of those 3 with a regular rhythm. The next thing you're going to do with the rate is, okay, you determine is it fast or slow based on what that number is of beats per minute, right? But now we got to check to see, is the rhythm regular or is it irregular? And if it is irregular, is it regularly irregular or is it irregularly irregular? And so what does that mean? So let's look at this one. Okay, this interval, and part of this is going to be an I believe. Okay, so this interval here is the same as the interval to this R to R, which is the same as this interval to this R to R. So this would be a regular rhythm, right? Let's look at this one. This interval here to here is not the same as the R to R to this interval, right? But if I superimpose this interval onto this interval, that's also different. So you can see, I can't superimpose and see that there's 2 intervals that are equal to each other. They're completely different from that R to R, and they're not consistent with any of the other R to R's in that interval. So that would be an irregularly irregular rhythm. Well, let's look at this one. So we all know that that's A flutter, right? And it looks like there's like a 2 to 3 and a 3 to 1 conduction ratio. So you see 2 P waves for every QRS in some instances, and you see a 3 atrial flutter waves per QRS in other intervals. And so when you look at this, this R to R does not equal this R to R, right? But if I were to superimpose this R to R onto this one, that would be equal. So you can see there is a consistency there. It's still irregular because you don't have that consistency from this beat to the next beat. But it's like every odd beat is consistent and every even beat is consistent. So that would give you that regularly irregular rhythm or rate, right? Does that make sense? So next we got to look at our intervals. So there's a reason we have to know what a normal interval is, and it's not because I want you to remember random numbers, right? It's because if I can know what a normal rhythm is, or normal interval is, and I can know what an abnormal interval is, I can actually determine the pathology that's present in that patient's heart even before I do any other testing. Okay? So PR interval, we said, to be sinus has to be at least 3 small boxes, but it can go up to 5 small boxes. And when you have an increase, so that one example I showed, it was like 6 small boxes, right? Now we're looking at that interval being increased. It is most likely a first-degree AV block present there. If that interval is decreased, it could be either pre-excitation syndrome, which we'll talk about in a later lecture, or it could be a junctional rhythm. So now the SA node is not driving that rhythm at all. When we look at QRS, so normally it should be less than 0.1 second or less than 2.5 small boxes. You can see there's really not a good pathology that shows that being, smaller. So that's not relevant to us. But we can get wide complex QRSs where now that QRS duration is larger than 2.5 small boxes or more than 0.1 seconds. And if you see that increase or that widened QRS, then you should be thinking of bundle branch blocks. Maybe it's a ventricular ectopic beat. Maybe it's toxic drug effect, or maybe you have hyperkalemia. So there's different pathologies that can affect that duration of the QRS. And then when we look at the QT interval, which we also talk about QTC, which is corrected QT, and this is something that we use when the heart rate is greater than 100, because you're going to get some distortion of the QT if that heart rate is fast. What ends up happening, if you have a shortened QT, could be hypercalcemia or it could be tachycardia. So that's why we do that corrected QTC for somebody greater than 100. If it's increased, it could be hypocalcemia, hypokalemia, hypomagnesemia. So low electrolytes will delay the conduction, so it's going to prolong that QT interval. It could be toxic drug effect, things that cause QT prolongation, right? So there's a number of things. Just looking at those intervals, you can get an idea of what's going on in that patient simply by seeing some of these distortions of the normal intervals. Now let's look at the axis, which tends to be one of the things that challenges folks the most when you're trying, especially like if you're using like the T method to do this. But ultimately, what we're looking at when we're looking at the axis is we're taking the sum of all the vectors of that action potential as it's moving through the heart, and we're trying to determine where that sum is. Now it should be between -30 degrees and +90. So it should be anywhere from, so this is our superimposed thing here, so it should be anywhere from here to here. This should be our normal range. And the reason that that's our normal range is, remember, heart's kind of twisted and tilted back, but the left ventricle in a normal heart has more mass to it than the right side does, right? And so if I have more mass, that means I have a larger action potential, some vector going that direction. So that's going to distort it over to that left lower quadrant on our little quadripods there. If it is shifted over to the right, now I'm looking at potentially like this mass, or that some of those vectors going to the right are larger than it is going to the left. And that's not normal. The right should not have the greater sum, because it shouldn't be greater mass or shouldn't have more action potential going to the right in a normal heart. If it's above -30, and now we're in like this range here, you can see what's going to happen with that is now you're talking about either this area is dead, so that only the action potentials are going in this direction, or there's a number of other instances where it may shift it over to the left that we'll talk about. But you can see kind of how that sum of that vector can distort the axis of EKG and the axis of our heart. So how can you determine the axis? Well, there is the T method, the isoelectric Lindley T method, which is a little more complicated, but it's going to give you kind of like the closest, more accurate assessment of which axis you have. But for the sake of this block, 1 and 2 is really all that you need. Okay. So we're going to do the quadrant method, which is a 2-lead method. And then you only need to use the 3-lead method in a specific situation, okay? So to do the quadrant method, take lead 1 and put it in your left hand, and then take lead ADF and put it in your right hand. And basically you're going to put your thumbs in the direction of the QRS. Which way is it going? If the the QRS in lead 1 is going up, thumb goes up. If it's going down, it goes down, okay? So if it's positive in lead 1 and it's positive in ADF, then that's normal. That means they have a normal axis. But unfortunately, that only gives you a normal axis of 0 to ADF. So 0 to plus 90. So you're losing out on this normal axis, which we'll talk about in a couple of seconds. But if the lead is down in 2 and down in AVF, you have an extreme right axis deviation, which is what was going on in the patient that was transferred to me in the middle of the night for an abnormal EKG. So down in 1, down in AVF, extreme right axis deviation. If it's down in 1, but up in AVF, now my right hand is in the upward position, but my left hand is in the down. That tells you that they have a right axis deviation. And then 4 is a special situation where we then have to go to the 3-lead method in order to determine exactly what's going on. So in the 4th situation, what's happening is you're up in lead 1, but you're down in the AVF. So it's kind of looking like this is a left axis deviation, right? But remember, the 2-lead method only gives you that 0 to plus 90. It doesn't give you that 0 to negative 30 component. So this is where that 3rd lead comes in to help us identify, is this a true left axis deviation, or is this in that 0 to negative 30 range and you have a normal axis? And what that's going to look like is, let me replace the AVF, so the right hand, with lead 2. And now put lead 2 in your right hand and move your thumb in the direction of the QRS in lead 2. If you're up in 1 and you're up in lead 2, then you have a normal axis. But if you're down in lead 2, then you have a true left axis deviation. And that's what we see on this example of this EKG. So we're up in 1. Let's see, where's my cursor here? So we're up in 1. We're down in AVF. Okay, so it's looking like a left axis deviation, but we don't know if it's that 0 to negative 30. So let's look at lead 2. And we are down in lead 2, so this confirms that this is a true left axis deviation. So what can cause a deviation to occur in the first place? What pathologies can cause this? Think of it as either that area is bigger than normal, so you have more of a action potential propagating down to that range because that mass of that structure is larger. So in this case, with this left axis deviation, we're looking at a left ventricular hypertrophy. It could be that the opposite side of the heart is dead, so you don't have any action potentials going in the opposite direction to counteract the force going this way, right? So without this, it looks like all of our sum is going that way. So an inferior wall MI is the opposite of the left axis. So if that area is dead, and I don't have action potential propagating down in that direction, I'm going to get that axis deviation. Another thing that can cause a deviation is if the propagation of that action potential into that region is delayed. It can cause that axis to deviate. And we can see this in left, like for left axis deviation, we can see that with left bundle branch block and like left vesicular blocks, because what's happening is with that left bundle branch block or that left vesicular block, the conduction of that action potential is going to go down to the right side normally, and then it's going to be slow as it propagates from myocyte to myocyte over to the left to cause that depolarizing event to occur in the ventricle. So now what's happened is all of those action potentials going to the right are done before the left starts to get that depolarizing event. So now you don't have any opposing vectors of action potentials to counteract that. So it's going to make it look distorted and look like you have that left axis deviation. Does that make sense? Okay. So you lose that opposing force. Basically what's happening in both the MI and also in the blocks. When we look at a right axis deviation, let's confirm that this is in fact right. So we are down in 1, down in 1, and we are up in AVF. So this confirms our right axis deviation. Things that can cause this are similar to what we saw with left axis deviation. Either the mass on the right is larger than normal, so you're having more of a vector going down that way, or the opposite side of the heart is dead. So if you have a lateral myocardial infarction, you lose the vector going to the left or to the lateral part aspect of the heart, and now it looks like it's all going towards the right. You're going to get that right axis deviation. Or in situations where basically the right side of the heart, the right ventricle, has to work much harder to get blood out of the right ventricle. So it's going to exert more of an effort. So pulmonary embolisms, large pulmonary embolism, pulmonary hypertension, which is a chronic thing normally, right? Unless you have like an acute thrombotic event, that blood clot getting up into the left side, you're not going to see a sudden change in the blood pressure of the pulmonary system. And then of course COPD is a chronic thing that can lead to a right axis deviation. Well, then you have the extreme right axis deviation, which we said was you're down in 1, down in AVF. The most common thing for this is going to be a limb lead reversal. There are some other things, but if you're going to have some of these things, you're going to see other arrhythmias present on your EKG to suggest that it's going to be almost impossible to determine what the axis truly is because you have that arrhythmia present. Let's look at the P waves and then we'll break for our break. So the P waves normally has this little hill kind of appearance to it. And it's made up of, the first part is that right atrial depolarization, which gives you kind of this triangular component to it. There's a delay of that left atrial depolarization because we have to get that signal across Bachmann's bundle into the left to trigger that depolarizing event. So then the second part of your peak is actually the left atria depolarizing. And when you sum the total of the amplitudes of both of these, you get that normal appearance. However, if you have a right atrial enlargement, you're going to get a distortion of the beginning part of your P wave. And so what's going to end up happening is you're going to get a quick peak to your right atrial enlargement, and you're going to get that kind of that distorted look to that P wave. If you have left atrial enlargement, what's going to end up happening is it's going to prolong that P wave. And you can see with left atrial enlargement, now I get that prolonging of the P wave. And it almost looks like there's two little dips to it. Because you're going to get that increase to the right atria depolarizing. And then there's that delay or that prolonging of that left atrial depolarizing event. And it's just going to drag it out, and you're going to get another little peak to it. Okay. Let's go ahead and take 10 minutes, come back, and we'll finish up. 35 of 85 slides. We are going to get through it. The last half of this lecture is just like, this is what a lateral MI looks like on your EKG. And this is why in the anatomy, why it's like. So we'll flip through a lot of those things. One thing I do want to say, tomorrow for our lecture, it won't be lecture 2 in our series, it's going to be lecture 3. Okay? And the reason for this is I have to move one of our lectures to the following week, so not next week, but the week after, because I have to go and do the help of the seniors in doing it in this block, and then we'll come back to lecture 2 for the 5th lecture. Okay. So we're working through still on how to read an EKG. We just looked at P waves. Let's look at now abnormalities of the QRS. First and foremost is looking at that horizontal axis of your QRS. We already looked at the frontal QRS plane by looking at our axis, right? Now let's look at our horizontal axis to see, is it in the right direction? So in a normal person, V1 should have the most negative QRS, and V6 should be the most positive QRS. So you'll see this transition of a negative to positive QRS as it works its way around to the left side, the lateral side of the heart. If for some reason there's a rightward tilt, so like a right axis deviation, right ventricular hypertrophy, something like that going on, you're going to see that opposite, where now you actually are mostly positive in V1 and mostly negative in V6. So when you look at different EKGs, look at the QRS and that propagation of that QRS complex. Next thing you're going to be looking at is how wide is that QRS? A normal QRS should be less than 0.12 or 3 small boxes. That is a normal QRS, which you see in this example here. But if it's larger than that 3 millimeters or that 3 small boxes, then that is a wide complex QRS. You might be wondering why this example is wide. It's because this is actually part of, it's kind of a weird distortion to it. So it prolongs, that S wave is prolonging that QRS complex. The other thing you're going to look at is it grouped? So look at this. So we've looked at, like, counting R to R's and stuff, but this is a bigeminy where you get like beep, beep, pause, beep, beep, pause, and you can see it's consistent, right? So this would be a bigeminy rhythm because of that QRS arrangement there. And then you also look for drop beats, which we kind of already did this when we were looking at, is this a sinus rhythm or is this an arrhythmia, right? But here again, we're checking to make sure that there are QRS complexes for every P wave, and that the P wave is preceding the QRS complex in the first place. Next, we're going to look and see, is there evidence of right ventricular hypertrophy, which this is kind of the criteria for it. So we said right ventricular hypertrophy is one of the causes of right axis deviation, one of the more common ones, right? So we're going to see right axis deviation in that right ventricular hypertrophy. We're going to see that reverse R wave progression where mostly positive in V1 and mostly negative in V6. We're going to see the S wave persisting in the lateral leads, and we're going to see a strain pattern, so like your T wave inversions or ST depressions present in V1 to V3. That's what you're going to see in a right ventricular hypertrophy. If you're looking at a left ventricular hypertrophy, now you have that left axis deviation that we talked about, you're still going to have that strain pattern, but it's going to be now in your lateral leads, not in your V1 to V3. And you're going to have that S wave in V1 or V2, whichever one is greater, plus the R wave, so how many millimeters that R wave is in V5 or V6, whichever is greater. If those two added together are greater than 35, then you have left ventricular hypertrophy. Okay. Now let's look at the ST segment. This is, of course, where we earn our money when we are looking at the EKG, outside of identifying arrhythmia or not, because this is, the most common cause of cardiac disease in the United States is coronary arterial disease. This is where we're going to see a lot of those changes. So, and we talked about this in block 2, so we'll go through this relatively quickly. So you're going to look at the baseline, which is basically like what is your P wave, and just draw that out, and you're going to see that's our baseline. And now you're going to compare that J point to that baseline. And what you're going to see is if it's above that baseline, then that is a elevation. If it is below the baseline, then it's a depression, right? Other things you're going to look at is my T wave asymmetric or symmetric? So like an example of this is, look at how it is going up. It's kind of a slow, gradual process, right? But then, when it goes down, it's abrupt. So that's asymmetric in appearance. You can also see, is it peaked, which is a drastic upright, right? Is it broad, where it's greater than one large box in the limb leads or greater than 2 large boxes in the chest leads? That just shows you that there's a prolongation of that repolarizing of the ventricle. And based on what we're seeing, can kind of give us an idea, is there evidence of ischemia or is there evidence of an infarct, so cellular death occurring there? And we can look at it again. You see that ST elevation, this indicates a transmural, so the full thickness is suffering from that lack of supply, and it's under severe stress to dying. If it is a ST depression or T wave inversion, this indicates a subendocardial ischemia, so it's a very localized, contained area to the most at-risk area of the myocardium that is suffering from that reduced oxygen flow, but it's not a full thickness cellular death. And there's some other things that you may see on a T wave. There's things called like a hyperacute T wave that's present that could be indicating an early infarct. But again, the J point is how we are going to determine that. And that is comparing what your baseline is to where that transition from the S wave into the T wave starts. And when we look at it, if it is in any lead other than V2, V3, you have to have that one small box or 1 millimeter or 0.1 millivolt elevation in 2 contiguous leads. If it's in V2, V3 that you're seeing that elevation, you get a little more of a leeway before you can call it a ST elevation. But remember, look at your calibration of your EKG to make sure that it is calibrated normally. Otherwise, this criteria may be altered based on that. So if you have it where now there's an auto calibration, so now 1 millivolt is actually 1 large box or 5 millimeters, then your criteria is actually in half. So now, and except for V2, V3, it's half a small box, half a millimeter elevation is considered an elevation. In men, in V2, V3, it would be 1 millimeter elevation, and in women, the 0.75 millimeter elevation would be considered a true ST elevation. So just check the calibration. And when we start to see ST elevations on our EKG, we can determine, based on where those ST elevations are, which coronary artery is being impacted by that perfusion deficit. And you may be wondering, well, why is that? Well, this is your anatomy compared to your EKG leads and what areas of the heart you're looking based on those EKG leads. And you can see, like, let's say we have a septal STEMI going on. So you'll see an ST elevation in V1, V2. It's supplied by the left anterior descending. And here's an example of that. So when we look at V1, V2, here's an elevation. And then here's definitely an elevation. Granted, when you look at other leads, you're going to see elevations too. Because septal infarcts in isolation are rare. So you're going to see probably more of a septal anterior or anteroseptal infarct. So you're going to see some carryover of that ST elevation into the anterior leads. When we look at an anterior MI, we're looking at V3, V4 is where that elevation is going to be. Again, it's a left anterior descending coronary artery that provides the perfusion to this area. And you can see, here's your V3, V4 region. Look what coronary artery is right there. Left anterior descending. So that's why we can determine that if you see an elevation in V3, V4, that it's the left anterior descending that's the problem. And you can see that on this example. So you're seeing V1, V2, because this is an anteroseptal MI. But V3 definitely has it, V4 even has it. And then by the time you get to V6, you see it's actually normal. Looking at a lateral MI, leads 1, AVL, V5, V6 are going to be showing ST elevations. And the blood supply for this is going to be your proximal LAD and your left circumflex. There's a little watershed in this region from your left anterior descending. So can you have ST elevations in V5, V6 with a left anterior descending occlusion? Yes, you can because of that watershed area. But typically you're going to see ST elevations in V1 through V4 as well. And that just kind of shows you an example of that. Now, the posterior area is also important to look at. But you can see how that circumflex kind of wraps around the heart and hits that left lateral area of the heart, or that left lateral wall of the heart. But then it also does tend to send a branch out over to the posterior wall too. But with a elevation in the lateral leads, so V5, V6, you're going to see that that's consistent. You can even look at leads 1 and AVL, kind of see that elevation there, because actually your baseline, your baseline is just a little elevated there in AVL. But here's an example of definitely showing that ST elevation in 1 and AVL. So this would make you think of this definitely like a circumflex kind of occlusion. Now, inferior wall MI. So 2, 3 AVF is your inferior leads, right? Well, what provides perfusion to the inferior wall? It's the right coronary artery. But what else does the right coronary artery provide perfusion to? Well, here's your right ventricle. So it's going to provide perfusion to that. But it also provides perfusion to the posterior wall as well. In a lot of patients, the primary artery to perfuse the posterior wall is in fact the right coronary. So when you have an inferior wall MI, we got to determine, is this isolated to just the inferior wall? Or does this involve the right ventricle? So we're going to need to do that right-sided EKG. but because a large portion of the population get their perfusion to the posterior wall from the right coronary, we also should do a posterior EKG as well to make sure we're not having perfusion deficits to the posterior wall. And this just kind of shows you an example of an EKG that shows elevations of 2, 3, and AVF. Shows you that occlusion area of the right coronary. And what's gonna look like when you do those right side of EKG leads is now those leads that you moved are going to show that ST elevation present. As you can see here now in your V4R, V5R, V6R. And this is the location of those leads when you flip them to a right-sided EKG. And this just shows you, okay, we flipped the lead, here's that ST elevation present in our V4R lead. Okay. Posterior walls. So we said, look for posterior wall MIs with evidence of an inferior wall MI because of the blood flow from the right coronary artery perfusing the posterior wall. But there may be some other changes that we can see on our EKG to make us suspicious for a posterior wall MI. And that's where you have reciprocal changes in V1 through V3. And this is what you're going to typically see. So you're going to see that profound kind of dip into your S wave, but then you're going to see that kind of ST depression present there in V1 through V2. And when you do your posterior leads, you're going to see that ST elevation present there. And the leads, the locations of the leads, so you're going to leave V6 where it is, and then V7, V8, V9, V10 in that area on the back of your patient. But this is what the reciprocal changes for a posterior wall MI is going to look like. We call it the carousel sign because it almost looks like that QRS kind of deflection into the S wave, and then that ST depression kind of looks like somebody riding a carousel horse. So if you see the carousel sign in V1, V2, be suspicious for a posterior wall MI. And here's an example of that. Imagine that's a saddle that somebody can sit on as they're riding around on a carousel horse. Another condition to be concerned about is a Welland syndrome. So we talked about left anterior descending, we talked about left circumflex, we talked about right coronary, but we haven't talked about the left main coronary artery, which provides the perfusion to not only the left anterior descending, but also the left circumflex. So you can imagine, if we have an occlusion up this high, imagine the devastation that's going to occur if that occludes 100%. And now you have no perfusion to the left anterior descending and no perfusion to the left circumflex. And this is Welland's syndrome when this occurs, where you have this critical high-grade occlusion of the proximal LAD or the left main coronary artery. To the point where if you see this on an EKG, they potentially have 8.5 days before they're going to have a massive MI if you see this finding. And there's two types that you might see, okay? So there's Welland syndrome type A, which is the less frequent version of this, which is a biphasic T wave in V2, V3. If you see this on an EKG, especially if it acutely changed, they probably are going to have a massive heart attack within 9 days if you don't do anything about it. Type B is the most common one, so 75%. And this is, you get this profound deep T wave inversion in V2, V3. It almost looks like a well, right? So Welland's looks like a well in V2, V3. Typically V3 is deeper than V2. But if you see this, then this is the most common form of Welland's that you're going to see, and again, will mean that they have a high risk of having a massive heart attack within the next week or so. And here's an example of that type B on your EKG, seeing those deep well-like T waves in V2 and V3, with V3 being deeper than V2. And then we talked about Q waves, and we've talked about how this is an indication of a prior infarct if it's a pathologic Q wave. And the reason for this is what's happening is, so we have that lead that shows that Q wave looking through that dead tissue, and because there's no vector coming towards it at all, so you don't have a vector going that way, all you're seeing is a vector going in the opposite direction. So it's going away from that positive lead, which then gives you that Q wave, because that action potential, as some of that vector is going away from the lead that's showing that Q wave. But you don't see that Q wave if I'm looking at electrode B here, like in this example, you don't see that Q wave here, because what is it doing? That vector is going towards that lead, so you see that positive deflection going towards that lead. So you're going to see some other changes like the ST depressions and stuff like that, but you're not going to see that pathologic Q wave present in that area because the sum of the vector is all going towards that lead. Now, you talked about reciprocal changes in your EKG class, and reciprocal changes are only present when there is an ST elevation in other leads. And basically what's happening is, when you have an MI going on in one area, because of the distortion of the action potentials, you're going to see those changes occur in the opposite directions. And the way you do PALs here can kind of give you an idea of what leads you anticipate to see these changes. It's not like you have an inferior wall MI and you start to see ST depression, T wave inversions in the lateral leads and the anterior leads. This is not meaning that they have a STEMI affecting the right coronary artery, and now they're having a NSTEMI or even a unstable angina affecting the left anterior descending and left circumflex, right? That's not what's going on. It's just because there is a distortion of that normal conduction of that action potential through the heart and through that infarcted area, we're going to see the opposite changes occur in the opposite leads from that region of the heart. So the PALs can help you remember what leads you would expect to see those reciprocal changes. And this just kind of summarizes what we just said there for reciprocal changes. So here's an example of this. So what do we see? Well, I see ST elevations in 2, 3, and AVF. So those are our inferior leads. And when we look at our PALs thing, if I have an inferior wall MI, so here's where my MI is, I expect in the lateral leads and the anterior leads. So now we're talking about V5, 6 here, right? We're talking about V3 to 4 here. That's where we would expect to see those reciprocal changes. Do we see that? And the answer is yes. So my lateral lead, so 1 AVL, V5, well, maybe not V5, but V6. But I do see it in V3, V4 as well. What's interesting is you see it in V1, V2 as well. But there's reciprocal changes present there. Questions about reciprocal changes or anything that we've learned so far? Look at this EKG. Does this look normal to you? Should I call in for backup immediately on this EKG?
Yeah.
I gotta give you some context. Let's say that this is a 21-year-old marathon runner. Does that change this interpretation? And the answer is yes, actually. In this situation, it does. This looks scary as hell, right? This is I'm calling the ambulance and getting that patient out of my ER, or out of my clinic immediately to get them over to a cardiologist, right? However, their history of being an athlete changes what's going to happen. Does it make sense that if I have somebody who is a very, like an avid athlete who is physically active for extended periods of time, that there's probably going to be some compensatory changes that are going to occur to the heart to adapt to that high peak performance, right? So if I have that adaptation occurring, does it also make sense that this is probably going to distort your EKG a little bit? That's where Seattle criteria comes in. Now, is this applied to your 3 Mile Club active duty folks? For those who don't know what the 3 Mile Club is, in the Navy and the Air Force it used to be, you only had to run a mile and a half for your PT tests, right? So you only ran your PT test twice a year, so you did a total of running in 3 miles a year. So, does that person fall into this athlete criteria? No, it doesn't. What does is somebody who is involved in 4 to 8 hours a week at a minimum of intense physical athletic training. So this would be like your football players who are out on the field right now training for Friday night's game. It includes your college football athletes training for Saturday's game, or your professional football athletes training for Sunday's games, right? Although pro football has games every day of the week now. Not so special anymore. But this is important because there are going to be some expected changes to the EKG and to the heart. But the most common cause of death in an athlete, in a young athlete, is sudden cardiac death. Not necessarily an injury from their sport, unless they're race car drivers. But so, how can we determine if this abnormality I'm seeing on my EKG is a normal, expected, benign thing for an athlete versus this is a high-risk change that I need to get this person over to see a cardiologist as soon as possible? And the Seattle criteria helps us determine that. And you can see it's got a great sensitivity, so 98 to 100% sensitive depending on which study you use to determine that. Now, I don't expect you to memorize each one of these criteria. Just know from all of this, just know if you have an athlete that you have to apply the Seattle criteria. That's all I need you and want you to know about this, okay? I want you to look it up. If you have that athlete with an abnormal EKG, recall in the back of your mind Seattle's criteria and apply that to your EKG to see if this is benign or not. So what in that athlete EKG would indicate a benign pathology? So things like incomplete right bundle branch block. Early repolarization. This is probably one of the most common EKG findings you're going to see in your active duty folks. Okay? It's going to look like it's an ST elevation, but it's just early repol. T-wave inversions of V1 through V3 in your less than 16-year-olds. First degree AV block, sinus bradycardia. I mean, everybody here probably has sinus bradycardia right now. Sinus arrhythmia, Mobitz type 1, LVH or right ventricular hypertrophy, ST elevations with T-wave inversions in V1 through V4 in black athletes, ectopic atrial or junctional rhythms. In isolation, you may have like a left axis deviation, a left atrial enlargement, or a right axis deviation or a right atrial enlargement, or even a complete right bundle branch block in isolation. So if you just have this, just left axis deviation, that's fine. If you have just left atrial enlargement, that's fine. If you have right axis deviation, that's fine. But if you have 2 or more of these, then that is abnormal and requires a workup. So if they have left axis deviation and left atrial enlargement, they need that workup. Okay, that is an abnormal finding if they have two of those present. So what does an abnormal EKG look like in that young athlete? They have T-wave inversions. They have ST segment deviations if they have pathologic Q waves. We said a complete right bundle branch block is okay, but if they have a complete left bundle branch block, that is not okay. If they have a widened QRS, if they have an epsilon wave, which is what an epsilon wave looks like, if they have prolonged QT intervals, they have brugada, profound bradycardia, PR intervals greater than 400 milliseconds. So you can see a lot of these are more concerning signs present. So if you see any of those, then that warrants an immediate cardiac workup because they are at high risk of developing fatal arrhythmias leading to sudden cardiac death. Questions? So again, don't memorize all these things. Just remember, if you have a young athlete coming in with an abnormal EKG, then you have to go the extra step in applying Seattle's criteria and see if it actually truly is abnormal or if it is a normal EKG. So, all right, we still have the same arrhythmias on there because we haven't talked about that.